So my name is Tim on the ST4s at Heartlands. So presenting this paper, it's looking at perioperative outcomes in the context of mode of anaesthesia, patients undergoing hip fracture surgery, which is systematic review and meta-analysis. Very catchy title. So this was published in the BJA advanced release last year, but release in January this year. So the background to this, as you know, hip fractures are very common. 76,000 hip fractures in the UK each year. Significant functional burden on the patients and significant comorbidities and perioperative morbidities and mortality associated, which relates to quite a high median cost to the NHS of approximately £9,500 per patient. Majority of that comes from their ward stay, so it's perioperative costing really. Difficulties in current literature is generally based on small RCTs and exclusion of large observational trials. And there's been a lot of problems with variation in how outcomes are reported. So the aim of this paper was looking at a systematic review for the literature into the title essentially, so looking at all the patients who'd had emergency surgery for hip fractures and looking at how we define the perioperative outcomes, so the morbidities and mortalities. So this started with literature search, with the usual routes through OVIDs, a Cochrane Central Register, and they also looked through forward and backward citations from all those papers, and looking for these general key terms plus some variations of it which I haven't included. So we're looking at the type of anaesthetic, post-operative complications, and some of these outcome markers. So the eligibility for this included randomised controlled trials and observational studies, both prospective and retrospective. They excluded case studies and case series. So these were independently screened by two investigators in duplicates, and any disagreements between these screenings were resolved by a third independent investigator. And again, the risk of bias was assessed independently by two investigators. So initially 440 papers were identified, 32 duplicates removed, further screening removed another 341 from the abstracts, and which gave 67 full text articles, another 43 were excluded, and then eventually leading to a total of 32 papers. So this is just a quick overview of the papers that they've looked at. You can see it's very small, sorry about that. It's interesting, not a huge number of UK studies, only a few from sort of a bit further away. So the study characteristics that they found, so getting down to these 32 studies, they managed to get 19 of those studies to use for quantitative analysis. So the majority were retrospective observational studies, and that was one of the things that they quoted as being one of their advantages. Previous systematic reviews had excluded observational studies, and that the fact that they used these observational studies, there's a lot of large observational studies, which meant they could really increase their sort of patient numbers. So 19 were observational studies, 9 randomised trials, and 4 retrospective cohort studies. And the themes were looking at spinal versus GA, regional versus GA, and then some looked at high-dose spinals versus low-dose spinals, and some spinals versus things like lumbar plexus blocks. They did a sensitivity analysis on all the cases that were purely spinal versus GA. So looking at the results, they looked at a few markers. So looking at mortality, they found that throughout those trials there was no difference in 30-day mortality between regional and general, which was graded as moderate evidence. And there's corresponding forest plots for those. And they looked at cardiovascular events, so looked at acute myocardial infarction, which again they found no significant difference in rates of MI with modality anaesthetic. It's a sort of recurring theme here. And interestingly, pneumonia, which I was quite surprised at, again, they found no significant difference. A slightly increased rate of heterogeneity with that. Delerium, again, possibly surprisingly, again, they found no significant difference in all the studies from those. And we're getting quite high patient numbers in these, so we're getting sort of 20,000 patients from all the collated studies. This one was the most, showed the most heterogeneity between the study mortality, so this was probably the least robust of their outcomes that they found. And acute kidney injury, perhaps not surprising, there wasn't much difference in rates. And length of stay was the only one of their sort of markers that they found that was a small statistical significance, which favoured regional technique over general technique. But essentially, from the paper, they found that there isn't really any difference in outcomes based on the papers that they'd screened and reviewed with regard to 30-day mortality, acute MI, pneumonia, delirium, and acute kidney injury, and only really a small significant improvement in length of stay with regional techniques alone. So looking at the study, the advantages of the study, it got huge numbers, and they did try to put a lot of attention into how the studies reported the outcomes and the definitions, because there was a lot of variability in that. And that was one of the things they sort of quoted as sort of the weaknesses in previous studies, is that there's lots of ways that we define these outcomes, how we define mortality, how we define a cardiovascular event, and how we write things like pneumonia. So disadvantages, and possibly an advantage, is that they used observational studies, and they used very large observational studies, which meant they could really boost their numbers. But this did introduce potential bias, as did some of the RCTs as well, to be honest. And they didn't include adjusted data in their review as well. So there was potential to include more data. They chose to exclude the adjusted data. So, is the study original? Yes and no. It's looking at an area that's been looked at a lot before, but not many, if any, have looked at such large observational studies included as well. So the study is about perioperative outcomes in fractured knobs, essentially. They did exclude case reports, case series, and they used elective hip replacements as well. Was it a sensible design? They had a fairly pragmatic approach with their screening, looking at the outcome measures and their inclusion and exclusion criteria. Bias wasn't avoided really, in that they did say that quite a few of the studies did show some elements of bias throughout the various different types. But they did assess the bias using the Cochrane risk of bias tool, and most of those were deemed to be sort of on the low to moderate side. So they had at least made an effort to sort of quantify those. Again, the studies generally weren't blinded. It's quite difficult to do that, obviously, in this context. The screening for these was independent, with two separate screening people and a third person to independently verify any contentions with those. And in terms of statistical analysis, they used quite a lot of stats, and they had a very large sample size, and they did test for heterogeneity as well. So arguably fairly robust statistics. So in conclusion, there's generally, from what they found, there's no difference in outcomes whether you use spinal or general anaesthetic, based on this paper. They did still quote problems with large inconsistencies in reporting the outcomes. So I've mentioned before how we report mortality, the 30-day mortality, 1-year mortality, in-hospital mortality, how we define pneumonia, is it based on any particular criteria, and how we define renal complications, etc. So I don't think we can take it at complete face value, but it gives a fairly good overview that on the massive numbers of patients included in this, we're still not seeing a significant increase in a significant difference between the modalities. And then finally, just looking closer to home, In this trust and a few other trusts around the area, we have the REGARD study, which we've just finished last week. So that's looking at similar sort of outcomes. So it'll be interesting to see what happens with that and whether that gets converted into a larger trial. So yeah, any questions? Still time. Sorry, it's a very dry topic for Friday morning.
Could you go back to the regard just slide 4?
So this is a feasibility trial. I think it's looking at Heartlands, Warwick. And I think there's 4. There's 4 in the West Midlands, I think.
Yeah. So the key with this trial, and actually it's a criticism of the way that they've done this systematic review, is that if you go back to where you had, you don't need to, but if you look at their studies they've included, loads of them exclude patients with dementia from their delirium assessments.
Yeah.
And they are, of course, the patients that are quite far and away most likely to develop delirium.
Yeah.
And so to say that one mode of anaesthesia is better than another when you excluded the group that are at highest propensity to benefit from us knowing the answer, and kind of fundamentally undermines.
Yeah.
It's like doing a trial of whether it gives you an MI, excluding anyone with risk factors for an MI. It's kind of pointless. Which is, and that's where the REGARD trial is completely different, because they've got a different way of going about consent, which allows everybody to get included. Yeah.
And then, from my experience of it, they're fairly proactive in gaining that consent with, picking up the patients who can't consent.
Yeah.
I suppose we'll obviously get much lower numbers in this, but they'll probably be more significant than the numbers that we do get.
Yeah, well, 100 is the number that was agreed for the feasibility study, which goes from do an analysis on working out how big it needs to be in order to find out whether there's a difference or not.
We've got a decent trend in the end.
Yeah.
So that was really slow to get going.
Yeah, but it's kind of done all right.
I mean, as a workload for anaesthesia standards for hospitals, it's quite a big chunk of the acute care that we deliver, isn't it? And it's been a sort of contentious issue whether we do spinals or GAs for these patients.
I think other than the UK, a significant analysis of the preference needs to preference, which analysis we use. They feel what works well for them in these sort of scenarios. And it may be that it does work well for them because they use that